Okay, so hi everyone. I'll be talking about multiple sclerosis obviously today. So just as a brief introduction, I wanted to tell you that sclerosis is actually comes from the Greek word skleros, which means hard. And that's just what multiple sclerosis plaques are. They're hard plaques. Okay, it's stuck. So just a briefing on the demographics of multiple sclerosis. It's an autoimmune disease, a T-cell mediated type 4 hypersensitivity disease that is usually more common in females than it is in males. There's a 2-to-1 female to male ratio, and it's more common in middle-aged individuals, in white populations, especially those who live around the temperate zones, probably owing to the fact that there is low vitamin D. And it has a genetic predisposition. So there's the HLA-DR2 gene. Individuals who have this are more likely to develop multiple sclerosis. And there are also environmental triggers, such as cigarette smoking, UV radiation, and it's associated with EBV virus as well as HHV6. So just a briefing on the pathophysiology of multiple sclerosis. So it does have, as I said before, both genetic and environmental causes. And it's basically due to a loss of the tolerance of the body to myelin. So what happens is T cells, mostly CD4 plus T cells, as well as T helper 17 cells and T helper 1 cells, they attack the myelin of the body. And there's also an association between B cells and multiple sclerosis. So what happens is you have the normal nerve conduction here in a normal nerve fiber, and the T cells come and they attack the myelin. And what happens is it gets damaged, so the signals get distorted. There's also, if we're going to look at the radiology and pathology of the disease, it's a multiple sclerosis. So you're obviously going to have multiple plaques on brain MRI that are separated. It's known to be separated in both space and time. So the plaques are going to be separated in space, and then we're going to talk about the symptoms that are going to be separated in time. And this is a gross image for post-mortem for the brain, and you have this plaque. And it's a gray colored plaque, which shows multiple sclerosis. And a period of time has elapsed after multiple sclerosis. It's usually salmon pink if we diagnose it or if we see it at that time. So what happens is they take a biopsy and they manage to stain it using something called a Luxol fast blue pass stain. And there's rarefaction. This is exactly the region where multiple sclerosis has occurred. It's a bit lighter, as you can see in the area surrounding it. To the right, there's just an image of normal myelin. This is what myelin should look like, but you don't get that with multiple sclerosis. The lines are actually gone. And then there's this guy. He's Dr. Bernard mentioned him a few times. He's Jean-Martin Charcot. He's a French neurologist. He worked in the middle 19th century, and what he actually did was he had like around 15 eponyms. His name was everywhere. And one of the things that he developed, he's named after the Charcot's neurologic triad. It's a triad that involves cerebellar and brainstem symptoms that are seen in multiple sclerosis patients. So multiple sclerosis patients might present with nystagmus, dysarthria, and intention tremors. But the thing is, these are always sensitive. They're not specific to multiple sclerosis. And then, of course, there are other clinical features, such as the blurred vision due to optic nerve demyelination, that may be in one eye or both eyes. Internuclear ophthalmoplegia, usually patients have a difficulty moving their eye horizontally, but they don't have a problem converging their vision. They would have vertigo and scanning speech, hemiparesis and unilateral loss of sensation, acute myelitis with lower extremity loss of sensation and weakness of bowel and bladder function, changes in cognition, constipation, and pain. And the most common site of demyelination in multiple sclerosis is, of course, the optic nerve. So what happens is, if we perform a fundoscopy exam, this is what a normal optic nerve should look like. But with multiple sclerosis, you get demyelination, and this is what it actually looks like. So this is the demyelinating portion. Also, characteristically, there are centroscotomas seen in multiple sclerosis patients. So you have this black dot in the middle of a patient's vision. There are also certain signs that are associated with multiple sclerosis. They're sensitive but not specific, such as Lermit's sign or Barber chair's phenomenon. Patients experience a shock-like or electricity-like pain, shooting pain once they flex their necks, and this pain goes down to their arms, to their back, to their legs sometimes. And there's the Otoff's phenomenon. And Otoff's phenomenon is characterized by reversible exacerbation of the signs and symptoms, whatever symptoms that patient has, with anything that involves heat, hot or humid weather, sunlight, hair dryers, exercise, hot tubs, hot baths, and infections and hormonal fluctuations. And then there's the course of the disease. So there are 4 different courses that multiple sclerosis can go through. It can be a relapsing, remitting disease. You have the disease, you have bouts of the disease, and then the disease improves over time because of the demyelination and then the remyelination initially. And then it just gets worse. So a patient would have a certain symptom, and then over time, that symptom would not completely disappear. He'd still have it. And then there's the secondary progressive. So over time, that patient will get worse. And not improve. The primary progressive disease, he's going to just get worse from the start without bouts of relapse, remission. And the worst one is the primary relapsing form of the disease. The patient gets worse over time, and he will have, on top of that, exacerbations for the disease. This is the worst one, and relapsing remitting is the most common form of the disease. Okay, so if we want to diagnose a patient with multiple sclerosis, we'll obviously need clinical diagnosis. The history and physical exam are the mainstay of diagnosis, but nowadays, with the help of MRI, the T1 gadolinium is MRI is 90% sensitive. There are also the Dawson's fingers that are seen on MRI, and they're just plaques that form around the ventricle. They're in the veins, and they just look like finger-like projections coming out. There's also the evoked potentials, which are going to show slowing of the conduction of nerve fibers. And CSF results are usually non-specific, so we'd rather measure them during an exacerbation. These patients would have mild pleocytosis or lymphocytosis, raised proteins that are myelin-based because of the destruction of myelin, and oligoclonal bands. So as you can see here, this is what it normally should look like, but in a multiple sclerosis patient, you would have an exacerbation of the IgG bands. There are many lines of treatment for multiple sclerosis, and the problem is that immunomodulation sometimes does not work, owing to the complexity perhaps of the disease, or because we don't understand what truly happens in multiple sclerosis. So so it depends on what form we have. Treatment depends on what form we have. We can treat the acute exacerbation or prevent exacerbations, and then we can also provide supportive therapy for patients. Usually primary progressive multiple sclerosis is very difficult to treat, so it's just based on supportive therapy. However, relapsing remitting multiple sclerosis and secondary progressive type are usually treated using high dose glucocorticoids and then second line plasmapheresis. If we want to prevent exacerbations, we can use different forms of drugs. These include glutamer. It resembles the myelin protein. What it does is it decoys T cells from attacking myelin. There's also the interferon therapy that we hear a lot about, and it just diminishes the inflammatory response that results in the demyelination process. These are first-line drugs. There's also second-line natalizumab. It's obviously a monoclonal antibody that works against alpha-4 integrin in cells and is used in all patients who have failed first-line treatment. In secondary progressive multiple sclerosis, they're the same drugs, but we also have the anti-cancerous agents such as cyclophosphamide, methotrexate. Other disease-modifying agents are fingolimod. It's a sphingosine 1-phosphate analog and decreases lymphocyte migration, so there are fewer lymphocytes going to the CNS. Teriflunomide is also used. It's a pyrimidine synthesis inhibitor and lowers the concentration of active lymphocytes in the CNS. There's also dimethyl fumarate, and it's an oral agent, unlike the rest, It alters cellular response to oxidative stress and reduces disease progression. And then there's mitoxantrone, which is a third-line agent. It's a cytotoxic agent that kills T cells and is obviously used for multiple sclerosis. And then there's, since multiple sclerosis occurs more often in females than it does in males, pregnancy and multiple sclerosis is an area of ongoing research. So a pregnant female is more likely to have less multiple sclerosis exacerbations during pregnancy, but afterwards the symptoms of the disease are going to increase. Female patients are more prone to cesarean sections, and they are also more prone to having babies with lower birth weight. I'm just going to conclude with this case presentation, a very short one, just to let you know that although that's what multiple sclerosis, that's what's written in books and about multiple sclerosis, it may be, you may have like patients are your books, so you may actually have a different presentation. So this is a case of a 38-year-old male. He had headache for 8 weeks and visual disorientation for several hours and was afebrile and had a long history of severe depression. So the patient was sent for imaging, and this is the radiological image. So on imaging, this is the MRI, and it involved the cortex, surprisingly, although we know multiple sclerosis usually involves the white matter, and it also involved the white matter and the corpus callosum. And then there was a ring-enhancing lesion when imaged using gadolinium. So the patient was sent for surgery, and the frozen section was obtained. And what the pathologists did was they put a special stain, and this stain is known to showed a sunburst appearance of mitosis. So mitosis is characteristic of tumors, and this patient was actually initially given radiotherapy. He was diagnosed with glioblastoma multiforme, but post-op, actually, this patient showed this sunburst appearance and had actually multiple sclerosis. He was stained for macrophages, and these are the macrophages. The brown colored cells are the macrophages, are the foam cells that contain all the debris from the myelin, and he was actually diagnosed with multiple sclerosis in the end. So that's basically it. So rules don't always apply in medicine, and that's basically it. Thank you.